Dr. Sadiq and I trained together during internal medicine, and that shared training grounds us in the way we practice medicine even today.
Yeah, I think the initial formative years in internal medicine, really laid the foundation of not just how to treat, but even how to, deal with a patient. The foundation of what a disease is, what it means to the patient, and what it means to us as clinicians to be able to make a proper diagnosis, and more importantly, try and prevent the disease before it actually takes hooks into your system.
Yeah, I think that's what we are passionate about, preventing the disease too. But moving back to your internship days and post internship before our residency, you were always passionate about cardiology. I remember you were always in the cardiac ICU. What drove you towards cardiology? What attracted you towards cardiology, Sadik?
I think I just always loved cardiology
I
because
know, but what was it in
see,
it?
the thing with cardiology is it's not very complicated. It's quite simple. I mean, in the sense, you have your heart is not doing what it's supposed to do, then the rest of your body kind of starts to shut down. So the
Right.
heart is the central organ, which everybody says that the heart is just a muscle, the heart is just a pump, all it does is pump blood. But what you don't realize is that when the heart as a pump starts to fail, it affects not just itself, but it also affects every other organ in the body: the brain, the lungs, the kidneys, the pancreas. There are patients who go to pulmonologists with breathlessness, and the problem is actually in their heart. There's people who go to gastroenterologists saying that our stomach is getting bloated, we are having abdominal symptoms, but the problem again is in the heart. So I think that, and the thing is, once you do identify the problem and you do treat it in time, a majority of these patients, by the grace of God, start to come back to having a completely normal life. I mean, we see patients who have critical coronary artery disease, not able to do their daily activities, not able to even walk 10 steps. And then once you do an angiogram, you find the culprit, you fix it, you put in a stent or you do a surgery, and then they are back to doing the normal life. The person who couldn't run 10 steps is now running a marathon. So
Right.
it is something which you can actually see making a difference in day to day life, and the cure really helps the patients in changing their quality of life and improving it, so to speak. And it's also one of the fields where when you really focus on prevention, you can prevent a lot of life threatening diseases. So a heart attack, a coronary disease, is something that in a majority of people can be prevented with the right tools, and if it is diagnosed at the right time.
That's right. You spoke about heart being connected to all the systems, and that's what I'm passionate about too. I believe in systems biology, and I believe that we should look at the person as a whole too. And I think cardiology is unique because one of the fields where time matters, right?
Yes.
Like it identifying the disease at the right time,
Yeah.
the urgency, the immediacy of the treatment is very, very important in
Yes.
cardiology.
Yes.
But moving on, from the days of cardiology you've seen for the past,
Yeah.
I think 20 years
Yes.
now,
Yes.
like you've been in cardiology
Yeah.
for, you before our residency
Right.
also. What are the changes that you're seeing now? What are the interventions that are new? What's changed in your field,
I see,
Sadik?
cardiology is one thing that has really grown by leaps and bounds.
Right.
One of the common things we face, one of the common accusations we face as cardiologists is that cardiologists are ready to stent anything nowadays.
That's true.
It is not. What people need to understand is that you're not doing it because we want to do it. It's because we are able to do it now. For example, a lot of patients who come to me for an angiogram, they are very worried, they're very scared that angiogram, once we do it, will we become weak? Will we become bedridden? Will we not be able to walk? Because they had some grandmother in their family who had an angiogram that was done through the groin using such a fat tube, and they had to have multiple stitches there and all of that. That was in the
Right.
70s and 80s and even up
Right.
to the 90s.
Right.
But today it's all just a prick. Our sheath that we pass into the catheter is not even 2 millimeters in diameter.
Right.
So it is that thin. The patients go home the same day. So everything has become a daycare procedure. You do an
Right.
angioplasty, a major angioplasty, a patient goes home the next day. Patients come walking, go walking. Yes, it is a but you see, you have to also understand that it's a field where you're dealing with the heart, one of the most vital organs, and somebody
True.
comes in with a heart attack, there is a risk that is involved, and that risk has always been there. The difference is probably that with the advancements in technology now, with the minimally invasive techniques really taking hold, we've been able to mitigate that risk to a large extent. Like, say for example, the risk that was, say, around 20% in maybe 30 years ago, today is just 1%.
Right.
So the technologies have advanced, the quality of the stents have really improved, and India is one of the countries where you're getting cheapest drug eluting stents in the world, and they are on par with what are available globally. So the same Medtronic, Abbott, or Boston Scientific stent that you will get for, say, lakhs of rupees in the West, you're getting it in India for 42,000. So that's a very good thing. It's become very accessible. Cardiology has become very accessible to the masses. Unfortunately, there's a lot of misinformation and miscommunication that is led to a barrier between people who actually deserve the treatment and those who are actually getting it.
And we are here to break those barriers,
yes,
right?
Exactly.
So more information and more power to the patient.
Yes.
So I see that you're saving more lives, right?
Yes.
But I also see that a lot of patients are coming in younger.
Yes.
Why do you think that shift has happened, Dr. Sadiq? What do you see?
The fact of the matter is, whether we have an answer for it or not, something has changed in the last 5 years.
True.
It sounds very cliched to say that we live in a post-pandemic world, but that's the truth.
That's true.
Something happened, something shifted post-COVID, whether it is long COVID, whether it is the inflammatory response to the virus, whether it is a continued response to the virus that we are still facing. We don't know. We actually,
maybe even lifestyle changes that have happened over
yes, of course,
the pandemic.
Yes, one thing is related to the disease per se. The second thing is what the pandemic did.
Right.
It made us lazier. At least those who are not in the medical profession and those who are not teaching.
Yeah.
So apart from teachers and doctors, I think everybody else had a wonderful holiday for 2 years.
True.
Because employers realized that, especially in the IT field, that you don't need employees to come to the office to work.
Yeah.
You can save on transport, you can save on food, you can save on so many things. Just make them sit at home and work. You don't have to. The advantage also being that I have a couple of patients who come in from the IT field and they're like, sir, this work. I was like, what is the problem? You're working from home. You can exercise. They're like, at least we went to office. We had 9 punch, 5 punch, 5 o'clock. I'm done. Now my boss calls me at 2 a.m. He calls me at 3 a.m. Now I'm working from home. I'm available 24 hours round the clock.
Yeah.
That's one side of the story. Second side of the story is we've just.
Sorry. Yeah.
Okay. So that's one side of the story. The second side of the story is people itself. We've realized that we've become we've probably become more of couch potatoes. Netflix and chill has become our mantra almost every day. Previously, as a family, we probably go out to have food once a week or twice a week, whatever it is. But today it's like you want something, you want a burger, you want a pizza, you just take your phone, order it, 10 minutes, it's at your door.
Yeah, it's instant,
so access
Swiggy
to
and
junk
everything.
is...
Yeah, access. Yeah. Yeah. So I see that there is metabolic processes, there is lifestyle, there is obviously long COVID and all the other things contributing to younger patients, right? But when we screen them, do they look normal to you? What are we seeing that's off when we're testing them, right?
There's a lot of obesity that has come in. I have, if I see a BMI on my prescription that says 18 or 17, I look twice at the patient. Like, is it really so?
Yeah.
Because it's so used to seeing 26, 28, 29, 30, 35, 40
that's right.
that seeing a normal
Even
BMI
40,
has
like
become...
you said, yeah.
Yes,
yeah.
40, 45 is like...
Yeah,
you have 30% of patients who come to my outpatient
Correct.
who are morbidly obese.
Right. That's
Other
true.
70%
Which was
are
so
obese.
rare when we were in internal medicine, right? Which was so rare.
Exactly
like
what
just
I was
15 years ago.
If you ask me what has changed in cardiology, I remember when we were doing our medicine, we used to sit in the outpatient, somebody 30-year-old comes with chest pain, we'll just write, we won't even advise an ECG.
Yes.
We'll just write antacid or a muscle relaxant and send them off.
Pantoprazole and
And today, when a 30-year-old comes to me with chest pain, I am so scared. I mean, this guy should not be having an MI. I should not be missing that.
Correct.
I don't send him home until I put him on a treadmill if his ECG and echo is normal.
Yes.
I'm like, you do a stress test, show me that it's normal, then I'll tell you that it's not cardiac.
ECG and Tropa have become our, right, left and center, we're doing that.
So as we were just saying, a lot of patients come in with seemingly normal reports, and then they come and ask, doctor, how did this happen? How did this happen? And then I have a pretty challenging time trying to convince them that, a normal report does not always give the full picture.
True.
So, you trained in internal medicine, you worked as a physician for a lot of years. Then what?
I'm still a physician, Sadiq, don't forget that.
You worked purely as a physician for a lot of years, treating diseases.
Yeah.
So how did you decide to make the shift from, treating them only, from shifting from there to, focusing more into a preventive aspect of medicine, more of a holistic type of a medicine and cardiometabolic health? So what really prompted you to make this shift? Was it that even you faced a similar kind of thing where you felt that the normal reports weren't telling the whole picture?
So, I was in my OPD all the time seeing patients with diabetes and hypertension. And even before they were diagnosed with diabetes and hypertension. So a lot of them would come in saying, ma'am, I'm not feeling right? Their BP would be just borderline high, maybe 126 or something by 85, still not meeting the guidelines for hypertension. And they would have headaches, they would be fatigued, they had brain fog, they were not feeling right. And I would look at their cholesterol levels, I would look at their, the normal uric acid, everything. And within the normal range, lab range. But still they were not doing fine. So then I said, I wanted to answer these questions. And then I had people I would pile on medication after medication, be it for diabetes, be it for hypertension. But I was not changing the root cause is what I felt. So that led me to asking questions. How can I find out what are the root causes? I can't just send a patient saying that please walk more and eat better, right?
Yeah.
So what is happening? I wanted to understand those things. That led me to looking at exploring a few courses. That led me to functional medicine. It was a beautiful course, 1.5 years spent in understanding the pathophysiology we were taught, but never connected the dots, right? We remember in Harrison, we would always go to the treatment part of it.
Yeah.
We'd skip the pathophysiology most times, right? So it beautifully taught me how to connect the dots, why these things were happening. So now, when I look at those reports, I know how to read them. I look for, if I see a HbA1c of 5.6, I don't send them back if they're not feeling good. Then I see a HOMA-IR. Right? I'm checking their fasting insulin, I'm checking their fasting blood sugar. If their fasting insulin is at 40 and their blood sugar is at 90, that's showing me that the body is working extra hard
to keep it
at that level. So I'm not seeing the dysfunction yet, but it's happening in the body. So if I look at the LDL cholesterol and it's borderline, it's at 110, but if I see ApoB, which is raised to 130, I know the particle sizes are very small and very inflamed, and that person's going to end up with a heart attack soon, right? So I'm asking the genetics. That it all led from the practice as a true internal medicine physician, and I wanted to change how I'm treating the patients, preventing disease, and understanding why these disorders are coming in.
And these are the people who actually show up later with established disease.
Yeah, they come to you.
Yeah, by when they've lost the battle half.
That's true. I think our internal medicine training allows us to see the overlap. We were taught to think in systems, not silos.
Yes, very true. My teacher of cardiology used to always tell me that, if you want to be a good cardiologist, you've got to be a good physician first.
That's true.
Because medicine is like the grammar that ties everything up together. You can't just look with a tunnel vision at the heart alone, at the artery alone. You're not just a coronologist, you're a cardiologist. You see the heart as a whole.
That's true.
And unfortunately, in many systems, we are losing track of this. People are forgetting that they've started off with medicine and you're a physician at the base of it all. And that's the truth of it all. Yeah.
There's something else I wanted to bring up, Sadiq. Something personal. remember I was pregnant during my final year,
Yeah.
and we had exams coming up. And I'm very grateful for colleagues like you and our professor, our HOD, Professor Siraj, who's no longer here, but who understood that supporting women doesn't weaken the system, it actually strengthens it.
Very true. That is very true because, I mean, personally, I feel a woman is central to our life, to our home, to the place you work. There is a sense of calm and a sense of balance that women bring to wherever they are. I'm not saying this to flatter you, but it's a fact. I mean, ultimately, if you don't take care of the women around you, you're going to mess up big time and then you're going to be lost with nobody to show you your way home. Especially in medicine, that's very important because, I mean, all said and done, the amount of empathy that a female physician brings to the profession can never be matched by a man, no matter how much he tries. Probably it comes from the role that a lady plays as a mother, as a homemaker, as you know, the very foundation on which a home stands, that gives her that added capability that I'm pretty jealous of. You can say that.
Don't be jealous
But
of. We have to go through a lot to get that equanimity, Sadiq. So,
I know, but
yeah. Yeah.
take the win, okay?
Okay. You say so.
But I think we really need to make things easier for women in medicine.
True.
We need to respect and understand that what a man faces at work, yeah, it's challenging. At work, it's challenging for both men and women, yes. But whether you like it or not, the truth is that society has certain demands and certain cliches from a lady.
Very true.
At the end of the day, I can go home, throw my bag in one corner and go and fall flat on the bed. Nobody is going to bother. If my wife does the same thing, she's going to have to hear things from our parents, from our siblings, from everybody else around. The kids are going to say, Mama, I have school tomorrow, where is my tiffin? I have a project pending, what about that? There's no food on the table, you got to make sure you get. So we have to, it is not inequality if we cut women a little more slack. I feel we need to give them that place to grow, that place to be comfortable enough at their place of work. I mean, it should not be that a female physician has to choose between her job and her family. I mean,
It's true.
that should never be the choice. I mean, as a doctor, you want to work, you should have a secure enough environment where you can work, and you can work happily and go back home happily, and your work at home, which should your work in the hospital should be so comfortable that you feel like, okay, I'm welcome here. It's not that somebody is judging you, oh, she's not going to be available, she has other responsibilities. Yes, everybody has other responsibilities. I mean, I as a father have responsibilities. Nobody judges me for that at my place of work, so why should they judge you?
Correct.
I mean, I think we need to change that culture, and I feel to a large extent it is changing compared to, say, what it was 10 years ago. Today, women in medicine have a much more stronger footing, much more stronger foothold, and there is a lot more acceptance. And it's also that, they have you have found a balance, and I feel people also at the workplace have come to accept that yes, just because somebody is a female doesn't make her any less of a doctor. You're as good or probably even better than what I am.
Yeah, I think there's strengths from both genders, right? And we
Yes.
have to learn to use those strengths and
Exactly.
work together.
Exactly.
And not only at a workplace, I believe in it can't be doing the same things is not equality, right?
Exactly.
Equality is playing by your strengths.
Exactly.
At home, at work, at everywhere.
Normally
I
what
think-
happens is people say, oh, I am doing this. No, it normally happens when you're a postgraduate. Like, oh, I am doing 8 duties. Why can't she do it? Why are you being, she wants to be equal. No, let her do it. You don't understand. That is not being equal. See, there's certain things which you might do better than me. There's certain things I might do better than you. At the end of the day, we've got to complement each other.
And-
Only then the patient benefits.
and society benefits.
And society benefits.
That's
yeah.
true. That's very true. Well said.
So, for somebody in the 30s, 40s watching this, what do you think? What would be your recommendations? What lifestyle changes should they make so that they don't land up with major diseases?
Yeah, I think starting simple is the best way, right, Sadiq? Nothing complicated. You don't need to do 100 different tests. You don't need to, look at changing your diet in a very, very drastic manner. I think simple things, starting simple, managing your stress, having good 8 hours of sleep, that's very important. Just cutting down on ultra processed food, making sure that you're getting enough fruits and vegetables and a balanced meal, identifying metabolic issues early if possible, right? Meet a practitioner who's focused on prevention. It's not everybody is focused on that. Meeting somebody who's focused on prevention, understanding what your risks are. That's, I think, just starting there. And movement, of course. Movement is very important. Starting with these small steps go a long way.
I think people need to understand that, when we say prevention is better than cure, it's not just a saying that we're just throwing out there.
Yeah.
When you have the ability and the tools to prevent a disease, why do you want to wait until it starts affecting you and you want to go and then get the cure, and then you crib about how expensive the cure is? Yes, the cure is expensive. It's not just expensive for you, it's expensive for me as well. It's expensive for you as well.
Yeah.
Paying lakhs of rupees out of the pocket one fine day because you've landed up with a heart attack is expensive for me and you as well. But if you can prevent it, why not? Right? That's why I tell my patients prevention is not just better, it's also much cheaper than the cure.
I think it's hard for people to see the consequences because they're not going through that at the moment. But, educating them, talking to them about this regularly is probably the only way that we can change this perspective.
Well taken.
If there's one thing that we both agree on, I think it's that heart disease doesn't start with that chest pain.
It starts much, much earlier than that.
And that's where prevention belongs.